Welcome. My name is Stephan Windecker, and I'm fortunate to host this symposium on the SELUTION SLR technology together with my colleagues Robert Byrne from Dublin in Ireland and Ricardo Costa from Sao Paulo in Brazil. This symposium is sponsored by Med Alliance, and within the next 15 minutes, we have the privilege to introduce you to this new technology. My first question I will address to Robert. Robert, could you introduce us to the SELUTION SLR technology, how it works, and what is so special about it?
Thank you, Stephan. There's a couple of things to know about the SELUTION SLR technology. The first is that it's sirolimus based, and it's one of a small numbers of sirolimus coated balloons at the moment. The second is that the dosage of sirolimus is low, so it's 1 microgram per millimeter squared, and you'll know from paclitaxel coated balloons that they tend to use slightly higher doses, 2, most usually 3. The third thing to know is that the coating is a formulation of sirolimus with a biodegradable polymer. And as you can see on the slide, this formulation is applied in micro reservoirs, which are applied with an amphipathic formulation, which means there's hydrophobic and hydrophilic ends. And this is a way of ensuring that you can get drug load onto the balloon, and then when you get to the place that you need it, you can get it off the balloon and into the vessel wall.
Thank you, Robert. Let me turn to Ricardo. Ricardo, can you tell us whether there are any clinical data available with this technology at this point in time?
Yes, so the first in-human study was already conducted. There's an enrollment between December 2018 to March 2019, and 56 patients were enrolled at 6 sites in Asia. And it was very interesting to see that despite not being a very large cohort, there was a high prevalence of, I would say, a complex patient and lesion profile, including around 50% diabetics, and also a great prevalence of complex lesion morphology, such as very small vessels, bifurcations, and even total occlusions. As you can see in these graphs in the upper left side, these are the outcomes from the geographic endpoints at 6-month follow-up. And we have the changes in MLD from pre to post to follow-up. We don't see a major change between post and follow-up. As we move to the graph on the upper right side, we see the changes in percent diameter stenosis from pre to post and follow-up. And I would highlight here around 22.2% residual stenosis procedure, and at follow-up paired analysis around 30.5%. And in the lower side, we see the cumulative frequency distribution curve for late lumen loss within the treated segment. And it's interesting to see a quite narrow distribution of the late loss. The mean value was 0.26, few outliers, and then the one highlighted here by the red arrow, which represents the highest late lumen loss we had, and this was the case that had a TLR. This case is worthy to say that there was a ISR, which was less than 1/4 of the cases included in this study. Most of the cases were de novo, and this particular case was a proximal, I would say, ostium proximal circumflex that was firstly treated with a paclitaxel-coated balloon, and then was dilated with the study balloons. And this patient returned with a severe restenosis and it had to be treated with a drug-eluting stent placement.
So these were the data you collected in the study, and interestingly, you included patients with both in-stent restenosis but also de novo cases. Do you wish to share with us some representative cases, Ricardo?
Absolutely. So we have some very interesting cases. This case was a subocclusive diffuse in-stent restenosis in the proximal and mid LAD, and we can appreciate what's the result, optimal result at post-procedure, and a quite well sustained at 6-month follow-up. Now we have And what we call a hybrid approach is a diffuse disease in terms of a mid RCA and a more distal PLSA branch with a significant lesion as well. And in the mid RCA was a standard DES placed, and at the distal lesion was the Med-Alliance DCB treatment. And we can see a very optimal result at follow-up, at post-procedure, and at follow-up, we can see in this control case here, we can see a well-sustained result in the mid-RCA with the DS, and similarly, a very good result without any major changes in the proximal PLSA. And now we see a more distal branch of the left circumflex and a quite small vessel. And it's good to say that in our study, about 25% of this first-in-man study had a reference vessel diameter by QCA less than 2 millimeters, a good representation of very small vessels as well as this case. And we can see a post-procedure and follow-up, a very good result in the more distal segment. One of the targets of this type of technology has been addressed more recently.
Thank you. Let me turn back to Robert. We have seen now the data from the study. We have seen a few cases. Robert, where do you still see some unmet clinical need where this technology will fit in particularly well?
So I suppose there's a couple of things we can say. The first is, as you mentioned in your question or allude to, the results with current generation drug-eluting stents are actually quite good for most patients and most lesions. However, we do realize that most of the patients that we treat have a long life expectancy and will run into problems long-term, even though the results in the initial 12, 24, 36 months with drug-eluting stents can be quite good. Stent failure does tend to accumulate with time. I think when you talk about particular lesion types, in our cath lab, in-stent restenosis is still the area where we most frequently use drug-coated balloons, but also, as Ricardo showed in his case examples, small vessel disease, certainly small 2O vessels can sometimes cause symptoms and require treatment, and their stents aren't a good solution. Bifurcation carinas are also something that we don't have a good solution for, and we know that we should try to reduce metal at the bifurcation carina where possible. And finally, one area we're thinking more and more about is the high bleeding risk patients, and wondering if drug-coated balloon therapy in these patients offers potential for a shorter duration of dual antiplatelet therapy.
Now, another important consideration is that this technology uses sirolimus. However, most of the published data and evidence so far with drug-coated balloons comes with paclitaxel-coated balloons. What are your thoughts as it relates to the drug release?
So the first thing I would say is we have been using paclitaxel coated on balloon for many years, particularly in in-stent restenosis. And the results with this technology are good. There has been concern because of the concern that we saw in the peripheral arterial disease space regarding paclitaxel coated balloons and long-term safety events. So I think most of us would prefer to work with sirolimus on balloons if we had a good solution. And many interventionalists, I suppose, will remember back to paclitaxel-eluting stents and remember that the issues that we had with paclitaxel-eluting stents and suboptimal outcomes with regard to efficacy and safety. So I think we'd like to see development towards sirolimus instead of paclitaxel. We know that sirolimus is an easier drug to work with a broader therapeutic index, therapeutic window. So I think we have good options at the moment, but with sirolimus, we can expect better outcomes.
Any comments from your part, Ricardo? I would just add that, as mentioned, the historical data definitely favors sirolimus, both in terms of safety and efficacy. And even though we do have seen good results with this technology with paclitaxel, we do see recurrences. And I think besides being an option for better outcomes, is also an option for recurrences after paclitaxel-eluting balloons as well.
So another important consideration in PCI in general is the use of antiplatelet therapy. So maybe you share with us your routine practice after drug-coated balloons and how it applies to this technology. Robert, you want to start?
Yeah, I mean, I think we look at a couple of things, and certainly what the presentation of the patient is. If it's acute coronary syndrome, then of course we prefer 12 months of dual antiplatelet therapy, even if we're using a drug-coated balloon. If the patient has high bleeding risk, then we're happy to reduce that down to 6 as a rule. As regards stable patients, perhaps there's more discussion, more controversy. If the patient is not high bleeding risk, then we tend to prefer 3 to 6 months of dual antiplatelet therapy. If the patient is high bleeding risk, then we're happy to reduce the duration of dual antiplatelet therapy down to 1 month. We don't do universal 1 month if we don't have a good reason, because we think from preclinical studies that there are some evidence that effective balloons lead to a slight delay in arterial healing. So that's why we tend to prefer 3 to 6 months if the patient is not high bleeding risk.
What about your practice, Ricardo?
Yes, it's being followed with standard of care for DS, even though we don't have much data with DCB technologies for the duration, the optimal duration of dual antiplatelet therapy. I would say that if I'm in front of a patient with high bleeding risk, if I have the two options, even though we have a lot of studies now supporting a shorter term depth for DS, I would rather have a DCB if that's a feasible lesion for that.
So what are the next steps, and which trials do we still need?
So, I mean, Stephan, there is an IDE trial which is going on in the United States, and you're very familiar with that study. It's enrolling patients in the United States and outside United States. It's looking at in-stent restenosis, the indication I said that most people most commonly use drug-coated balloons for, and it's comparing the SELUTION SLR in 418 patients. It's comparing the outcomes of these patients compared with the control arm, which is a mix of therapies that are approved for use for in-stent restenosis, including plain balloon angioplasty and repeat stenting with drug-eluting stents. There's been an angiographic cohort study and also a clinical follow-up.
Ricardo, what else do we need?
I think I see a very good potential for this technology in situations like very small vessels, widely diffuse disease, and also as for bifurcations. We all know from several studies that a more simplified approach for bifurcation has become the standard of care, even though in more complex situations, a double stent technology as elective approach can be needed. And once we have, in the results we have in the study was quite interesting, because we are seeing even in more diffusely diseased side branches, this technology can work well and can have good results in long-term follow-up. So I see a good potential for bifurcations as well.
So there's actually one larger scale trial planned, including more than 2,000 patients, and together with Rob Byrne, Don Cutlip, and myself, we try to design this study where we look at patients with de novo lesions and try to compare this new technology with the established drug-eluting stent, looking at the primary endpoint of target vessel failure to be assessed at 12 months. Now, coming to the end, I wish to wrap up this symposium by summarizing that the SELUTION SLR certainly is a promising technology, releasing sirolimus in a sustained fashion from dedicated micro reservoirs. We hope that you learned a little bit from the first-in-man data, and we addressed some of the areas where this technology can be addressed, including in-stent restenosis, bifurcation, small vessels, and patients at high bleeding risks. And we also introduced you to potential future trials. I take the opportunity to thank Robert Byrne and Ricardo Costa, and I hope you enjoyed this symposium. Thank you.